Right now, like half the population is walking toward a really profound structural change in their anatomy.
Yeah.
It's a biological shift that, alters the fundamental integrity of their tissues. And yet 70% of them have absolutely no idea it's even coming.
It's just an incredible blind spot, isn't it? I mean, we're talking about a cascade of physiological events that dramatically impacts daily life, but...
But it happens completely in the dark.
Exactly. Completely in the dark.
So, welcome to the deep dive. Today, our mission is to unpack this massive, startlingly under-discussed reality for you. We're looking at how declining estrogen physically alters vaginal health, tissue elasticity, and, well, the surrounding urinary tract.
Right.
And we are pulling from a big stack of sources today. We've got clinical guidelines from the British Menopause Society, the NHS, the Mayo and Cleveland clinics, and some really revealing recent data on a landmark UK pharmacy reclassification for a treatment called GINA.
Yeah, and the goal here today is to really get into the actual mechanics for you. We want to move past that vague concept of, menopause symptoms and explain the why and the how behind what's actually happening at a cellular level.
Because it's not just hot flashes.
No, not at all. Unlike hot flashes, which, they are incredibly disruptive, but they often eventually fade. The anatomical changes we are looking at today are chronic.
They're progressive, right?
Exactly. They are progressive. Without intervention, the tissue simply continues to alter over time.
Okay, let's unpack this. I want to start with that 70% statistic from the UK survey data in our sources.
Okay.
According to the research, about 1 in 2 women will experience severe vaginal dryness, itching, and pain after menopause.
1 in 2?
Yeah, 1 in 2. But 70% of UK women have never even heard of the underlying medical condition causing it. I mean, people are walking around experiencing agonizing symptoms and believing they're just, breaking down.
Which is exactly why we have to start by establishing the baseline of a healthy system. To understand the decline, you first have to understand the environment before the estrogen drop.
Right.
And this isn't just a passive anatomical space. A well-estrogenized vaginal canal is an incredibly dynamic, highly regulated ecosystem.
Let's build that ecosystem for the listener, because based on the clinical data, estrogen receptors aren't just universally distributed across the body in equal amounts, are they?
No, they aren't. They are intensely concentrated in very specific areas. So the vagina, the vulva, the urethra, and this area called the trigone of the bladder.
Wait, the trigone. What is that?
Well, what's fascinating here is that the trigone is this smooth, triangular region at the very bottom of the bladder. And embryologically speaking, the lower third of the vagina and that part of the bladder, they develop from the exact same tissue when we're still in the womb.
Oh, wow.
Yeah. So because of that shared origin, they both possess an extraordinarily high density of estrogen receptors.
So they're intrinsically linked from the very beginning.
Completely linked.
And when those receptors are regularly flooded with estrogen during the reproductive years, the vaginal epithelium, which is the inner lining, is basically running on fast forward.
Very fast.
The sources say the superficial epithelial cells on the surface shed every 4 hours. I mean, think about how often you might exfoliate the skin on your face, maybe once a week.
Right.
But this tissue is turning over multiple times a day.
It is a massive expenditure of cellular energy, and it serves a really brilliant symbiotic purpose. Because when those surface cells shed every 4 hours, they release a sugar called glycogen.
Okay.
And that glycogen is essentially a food source specifically cultivated to feed a healthy strain of bacteria called lactobacilli.
Ah, the famous good bacteria.
Exactly. The lactobacilli consume the glycogen, and as a byproduct of that digestion, they produce lactic acid.
Which drops the pH.
Yes, this keeps the entire vaginal environment at a very low acidic pH, specifically below 4.5.
So it's basically a self-funding security system. If we think of estrogen as like the manager of a highly efficient factory, it pays the assembly line to move, so the cells shed. The shedding cells feed the bacteria, and the bacteria produce an acid shield that is completely hostile to outside invaders.
That is a great analogy. That's the surface level, yes. But estrogen's influence actually goes even deeper.
How so?
Well, if you look beneath that epithelial lining, down into the structural layer called the lamina propria, estrogen is managing a completely different operation. It keeps specific cells called fibroblasts awake and active.
And the fibroblasts are the structural builders. The sources note they produce type I collagen, which gives the tissue its raw tensile strength, right?
Right.
And type 3 collagen, which provides the elasticity, and they also pump out elastin.
all of which creates the characteristic folds in the vaginal wall, which the medical community calls rugae.
Rugae, okay.
Yeah, and those folds are crucial because they allow the tissue to expand safely, stretch during sexual intercourse or medical exam, and then instantly snap back to its resting state without sustaining any damage.
Okay, I'm going to pause here for a sec because I need to push back a little on the framing of this entire conversation.
Sure.
We're describing this beautifully orchestrated, high-functioning ecosystem powered by estrogen. But menopause is a completely natural, guaranteed biological phase.
Yes, it is.
So if the body naturally stops producing estrogen, isn't that by design? Like, why do the medical guidelines treat this structural shift like a disease or a mechanical failure if it's literally what the body is naturally programmed to do?
That is a phenomenal comment, and it really comes down to evolutionary biology versus modern medicine.
Okay, tell me more.
Historically, human beings just didn't routinely live for 3 or 4 decades past their reproductive prime. Evolutionarily, we didn't need to maintain that specific tissue's elasticity for 40 years post-menopause.
Oh, I see.
But today, a woman might spend a third or even half of her life in a post-menopausal state. The modern lifespan has drastically outpaced the natural design of the reproductive tissue. So we're dealing with an evolutionary mismatch. We have outlived our estrogen, but we still need the tissue to function comfortably for decades.
That makes so much sense. It's not that the body is broken, it's just that we are demanding it perform long after its natural warranty for that pelvic hormone has expired.
Exactly.
So let's look at what actually happens during that estrogen drop. Since you understand the factory baseline now, what happens when the manager retires? Whether it's natural menopause, surgical removal of the ovaries, or medically induced from chemotherapy, the estrogen plummets.
Yeah.
What is the immediate physical consequence to that ecosystem?
It is a profound structural collapse. Without estrogen binding to the receptors, those fibroblasts, the builders making the collagen, they go dormant. They literally change their cellular state, turning into inactive cells called fibrocytes.
And the existing infrastructure just starts degrading. Reading the clinical description of this in the sources is intense.
It really is.
The existing collagen fibers begin to fuse together. The clinical term is that they hyalinize, which essentially means they become glassy, stiff, and rigid.
Right.
It's like taking a piece of supple, woven fabric and coating it in wax. And the elastin fibers, which give the tissue its bounce, they actually fragment and snap.
And the visual and physical results of that are drastic. The vaginal walls lose those accordion-like folds, the rugae. The canal becomes completely smooth. It physically shortens and narrows. And because estrogen also stimulates blood flow, the reduction in circulation means the tissues become incredibly thin and pale.
Which brings up the concept of friability. Because, if the tissue is losing its blood flow, its elasticity, and its structural support, it actually becomes fragile, right? Does it break?
Yes, highly fragile. The medical term friable means the tissue can easily tear or bleed under minimal friction. Women develop petechiae, which are tiny, pinpoint red spots of bleeding just under the surface. And they can sustain actual micro tears just from everyday movement, from wiping with toilet paper, or certainly from sexual intercourse.
And while the structural integrity is collapsing, the security system we talked about earlier is also shutting down. Because without the estrogen, that fast-paced cell shedding stops.
Right, and if the cells aren't shedding, there is no glycogen.
Which means no food for the good bacteria.
Exactly. The lactobacilli literally starve to death. Without them producing lactic acid, the pH of the vagina spikes. It moves from that protective acidic state of below 4.5 up past 5.0, becoming much more alkaline.
And an alkaline environment is essentially rolling out the red carpet for bad bacteria.
It is. Pathogens from the gut, specifically E. coli, migrate over and thrive in that higher pH. This is why a massive subset of women in this stage of life suddenly experience chronic, severe vaginal inflammation and recurrent urinary tract infections. The acid shield is gone.
And this connects back to what we mentioned earlier about the trigona of the bladder sharing those exact same estrogen receptors.
Yes, exactly.
The urethra and the bladder are going through the exact same structural thinning and smooth muscle loss. So a person starts experiencing urinary urgency, frequency, and stress incontinence, literally leaking urine when they cough or laugh.
And it's important to note, it's not just because of weak pelvic floor muscles, but because the actual urethral tissue has lost its collagen seal.
Which is exactly why the medical community internationally has initiated a major terminology shift. I mean, for decades, doctors called this vaginal atrophy or atrophic vaginitis.
Which sounds terrifying.
Terrifying and deeply isolating.
It does, and it's also medically incomplete because it totally ignores the urinary tract. The updated clinically accepted term is now the genitourinary syndrome of menopause, or GSM.
GSM?
Yeah, it recognizes that the genital and the urinary systems are inextricably linked, and they're suffering from the exact same estrogen deprivation.
GSM accurately captures the umbrella of what millions are going through. Severe dryness, burning, painful sex, which the medical community calls dyspareunia, and the constant urinary issues.
Right.
And the sources point out this brutal itch-scratch cycle, too. The thin tissue is easily irritated, so it itches. But scratching friable tissue causes microabrasions, which trigger an inflammatory response, which just makes the itching worse.
It is agonizing.
So we return to that shocking question. If GSM affects 1 in 2 women, why are only about 7% receiving treatment?
Well, if we connect this to the bigger picture, it is a potent, toxic mix of cultural conditioning, embarrassment, and just a lack of proactive medical communication. The survey data shows that 78% of women do not initiate a conversation about these symptoms with their doctor.
78%.
Yeah. There is a deeply ingrained societal belief that pain, dryness, and urinary issues are just, well, a required toll you pay for aging. You're expected to just grit your teeth and bear it.
But physiologically, grinning and bearing it is the most dangerous thing you can do for the tissue.
Exactly, because GSM is chronic and progressive. Like we said, unlike a hot flash, which is a temporary neurological misfire, GSM is a structural change. If you do nothing, the collagen continues to hyalinize, the canal continues to narrow.
It just keeps getting worse.
Right. In severe cases of neglect, the extreme inflammation can actually lead to the labia physically fusing together. The longer you wait, the harder it is to reverse the damage.
Which means we need to pivot entirely to the solutions.
Yes, let's do that.
Because despite how bleak this anatomical breakdown sounds, the clinical guidelines from the NHS, the Mayo Clinic, and the British Menopause Society are actually full of incredibly effective science-backed interventions.
We have the tools to turn the lights back on in this ecosystem.
We do. And the absolute gold standard across every major medical body is local vaginal estrogen. Let's clearly define local, because a lot of people hear the word estrogen and immediately think of systemic hormone replacement therapy, like the patches or oral pills that circulate through your entire bloodstream to treat hot flashes and night sweats. Local estrogen is entirely different.
Entirely. Local estrogen comes in very low-dose creams, soft rings, or tiny tablets inserted directly into the vagina. It acts explicitly on the tissue it touches.
So it says local.
Right. It doesn't need to travel through the liver or the cardiovascular system. It is like sending a targeted rescue team directly to the starved receptors.
And the mechanism is fascinating. The sources explain that once applied, it absorbs directly into the lamina propria. It stimulates blood flow, bringing oxygen back to the area. It acts like a chemical alarm clock for those dormant fibrocytes, forcing them to turn back into active fibroblasts and start pumping out fresh collagen and elastin.
It restores the physical thickness of the tissue.
And crucially, it restarts the superficial cell shedding, which brings back the glycogen, feeds the lactobacilli, and drops the pH back down to a protective, acidic level. It is a complete restoration of the biome.
It really is. And the safety profile on this is what really stands out in the research. A lot of patients, and even some older doctors, fear prescribing local estrogen because of the controversial history surrounding systemic HRT and breast cancer risks.
Right. But the statistic in our sources puts the systemic absorption of local estrogen into incredibly sharp perspective.
The absorption is negligible.
Negligible is an understatement. Listen to this. If you use a standard 10 microgram local estrogen tablet like Vagifem or Gina, exactly as prescribed for an entire year, the total amount of estrogen absorbed into your bloodstream is the equivalent of taking a single 1 milligram oral estrogen pill.
One pill.
One pill spread over an entire year.
And that profound safety profile is exactly why we've seen such a monumental shift in how these medications are regulated, particularly over in the UK.
Yes. Let's look at that MHRA decision. The UK's medical regulatory body made a landmark ruling to reclassify the 10 microgram estradiol vaginal tablet known as Gina. They moved it from a prescription-only medicine to a pharmacy-only medicine.
Which is huge.
It's massive.
Yeah.
This means women aged 50 and over who haven't had a period for a year can walk into a local pharmacy, have a brief private consultation with the pharmacist, and purchase the gold standard treatment right over the counter. No doctor's appointment. No begging for a referral.
It completely bypasses the medical bottleneck. For the 78% of women too embarrassed to undress in a clinical setting or who simply cannot get an appointment with their GP, they now have a direct, autonomous route to treating the actual underlying cause of their pain, rather than just using a Band-Aid.
Speaking of Band-Aids, we need to discuss the non-hormonal options. Because, not everyone can use estrogen, particularly certain breast cancer survivors on specific estrogen-blocking therapies, or they may simply choose not to. But the market is flooded with products, and there's a massive functional misunderstanding about the difference between a lubricant and a moisturizer.
Oh, absolutely. They serve completely different biological functions. Lubricants are strictly for temporary friction reduction during sexual activity. They do absolutely nothing to alter the baseline health or thickness of the underlying tissue.
A good way to visualize this for you listening is through a skincare analogy. Using a personal lubricant is like splashing tap water on a really dry face. It feels wet for a few minutes, but it evaporates quickly and does nothing to heal the dry skin long term.
Right, and to take that a step further, a vaginal moisturizer is akin to a deeply hydrating night cream. Moisturizers are designed to be used regularly, usually every 2 to 3 days, regardless of sexual activity.
Oh, so it's a maintenance thing.
Exactly. They are formulated with complex polymers that actually adhere to the vaginal epithelium. They change the fluid content of the tissue, mimicking natural mucosal secretions, and many are formulated to help lower the pH. They don't rebuild collagen, but they significantly improve comfort.
And to finish the analogy, using local estrogen is like applying a powerful active serum like a prescription retinoid. It penetrates deep into the cells and literally rebuilds the structural barrier from the inside out. But just like a skincare routine, consistency is non-negotiable.
That's right.
If you stop using the active serum, your skin eventually reverts to being dull and dry. If you stop local estrogen, the fibroblasts go back to sleep and the GSM decline resumes.
Exactly. It requires ongoing maintenance. Now, for patients looking beyond traditional local estrogen or moisturizers, the clinical guidelines highlight several other emerging and established medical therapies that tackle this through completely different mechanisms.
Yeah, the sources mention intravaginal DHEA. What is the mechanism there? If it's not estrogen, how is it rebuilding the tissue?
Well, DHEA is a precursor hormone, often called a prohormone. It's an inactive steroid that the body actually naturally produces.
Okay.
When applied inside the vagina as a suppository, it utilizes a mechanism called intracrinology. The vaginal cells take that DHEA and use their own internal enzymes to convert it directly into both estradiol and testosterone inside the cell.
Oh, wow. So the hormone is manufactured locally on the factory floor, so to speak, rather than being delivered from the outside.
Correct. It exerts its effect locally to build tissue and improve sexual function without significantly raising hormone levels in the systemic blood circulation. And then you have oral options like ospemifene.
Which is a SERM, right? It's a selective estrogen receptor modulator.
Yes.
How does an oral pill fix the vaginal tissue without flooding the rest of the body with estrogen?
Think of a SERM like a very specific key that only turns certain locks. Ospemifene circulates in the blood, but it acts selectively. When it encounters an estrogen receptor in the vaginal tissue, it binds to it and acts like estrogen, triggering the fibroblasts to wake up and thicken the lining.
But what about breast tissue?
Well, when it encounters estrogen receptors in breast tissue, it acts as an antagonist. It actually blocks the receptor. So it provides the local benefits to the vagina without the systemic risks to the breast.
That is incredible pharmacological engineering. The guidelines also delve into physical procedures, specifically fractional CO2 laser treatments. Now, my immediate thought when I read laser in the vaginal canal was absolute terror.
Understandably.
How is burning the tissue a viable treatment for tissue that is already fragile and tearing?
It sounds totally counterintuitive, but it leverages the body's natural healing cascade. The laser creates thousands of microscopic controlled dermal injuries, tiny pinpricks of heat, into the vaginal wall.
So it's basically the exact same concept as microneedling or fractional laser resurfacing for wrinkles on your face.
Precisely the same concept. By causing a controlled microtrauma, it triggers an acute inflammatory response. The immune system rushes blood, oxygen, and growth factors to the site to heal the burns. And this massive influx of cellular attention forces the dormant fibroblasts to wake up and synthesize fresh, healthy collagen, elastin, and new blood vessels in the process of repairing the tissue.
It's tricking the body into repairing a chronic problem by introducing an acute, manageable one. It's really amazing how many scientifically robust tools are actually in the toolkit. We aren't just limited to one option.
No, we have quite a few.
And beyond the medical and clinical interventions, the sources explicitly highlight lifestyle factors that literally alter the physical structure, the most prominent one being regular sexual activity.
It is quite literally a use it or lose it scenario for the elasticity of the canal. Regular sexual activity, which includes penetrative sex, the use of vaginal dilators, or solo masturbation, physically increases localized blood flow.
And blood flow is life for this tissue.
Exactly. That mechanical stretching and the rush of circulation help maintain the elasticity of the collagen fibers and prevent the canal from narrowing over time.
Which logically explains why the guidelines flag smoking as a massive accelerant for GSM.
Smoking is a potent vasoconstrictor. It restricts and damages the tiny blood vessels throughout the entire body, suffocating the already compromised vaginal tissue.
And the chemicals do damage too, right?
Yes. Furthermore, the chemicals in tobacco actually blunt the effects of whatever natural estrogen your body is still managing to produce. It actively speeds up the degradation.
We have covered an immense amount of ground today. We zoomed all the way in to watch the estrogen ecosystem thrive with its rapid 4-hour cell turnover, its symbiotic lactobacilli producing protective acid, and its fibroblasts weaving a flexible collagen matrix.
We really did.
And we explored the evolutionary mismatch that occurs when the estrogen drops, the structural collapse that follows, and the profound urinary and physical pain that results. But most importantly, we mapped out how targeted local therapies, from over-the-counter tablets like Gina to SERMs to deep tissue moisturizers, can safely wake those cells back up and reclaim a person's quality of life.
And synthesizing all of this clinical data leads to a really crucial paradigm shift for you to consider. Well, in our society, we readily accept the daily need to apply moisturizer to our faces to protect our skin barrier. We lift weights and take calcium to protect our aging bones. We do cardio for our hearts.
We treat all of those as standard, respectable pillars of aging gracefully.
Right. So, what would society look like if we applied that exact same logic to our reproductive anatomy? What if we viewed postmenopausal vaginal health not as a taboo, embarrassing secret to be endured in silence, but simply as another routine, standard pillar of longevity and wellness?
That is a perspective shift I think millions of people are completely ready for. Thank you so much for joining us on this deep dive. Keep exploring your own biology, keep asking the hard questions of your doctors and pharmacists, and never stop seeking out the knowledge you deserve.